benign tumors arising from the choroid. It is a vascular tumor arising from the choroid. Other than melanoma, choroidal hemangioma and lymphoma, choroidal mets, all these form differential diagnosis of choroidal melanoma. Choroidal melanoma is a malignant tumor, hence it is important to know the clinical features and how to differentiate the other pseudomelanomas from the true melanoma. And choroidal hemangioma is a benign tumor which can cause a significant vision loss, and hence we have to know about the clinical features and about the management. In a malignant tumor, the primary goal of management is salvage of life followed by salvage of organ. Whereas in a benign tumor, the primary goal of treatment is improving the functional capacity of the organ concerned. So introduction, as I said, it is a benign vascular tumor arising from the choroid. It is of two types, circumscribed and diffuse. So demography, circumscribed choroidal hemangioma is a sporadic tumor. Slight male preponderance is seen. These lesions are said to be congenital. Basically, these are malformations. I will come to the genetic part little later. So they can be asymptomatic until the age of presentation, which is around middle-aged adults in case of circumscribed hemangioma, and pretty young patients in case of diffuse hemangioma because of the systemic features and glaucoma. So the diffuse type is associated with Sturge-Weber syndrome. Can anybody quickly tell features of Sturge-Weber? The cutaneous and the CNS features? Okay, so it is associated with unilateral nevus flemmus or Potvine stain and ipsilateral leptomeningeal hematomatous lesions, which will cause contralateral hemiplegia and seizures. Epilepsy is the most common presentation of patients with Sturge-Weber syndrome, and they land up in ophthalmology mainly to rule out glaucoma. The cause of glaucoma in very young age group will be goniodysogenesis, and in the later age group will be due to increased episcleral venous pressure manifested by blood in Schlemm's canal. So while the patient comes for a glaucoma workup, when we see the fundus, we see a diffuse orange-red hue in the fundus, and thereby we diagnose with diffuse type. On the other hand, the diffuse type may directly present with the exudative RD, in which case is mostly diagnosed with the help of an ultrasound. And the circumscribed choroidal hemangioma can be associated with systemic hypertension, and it is rarely associated with Sturge-Weber syndrome, neurofibromatosis, and other mucosal and remote cutaneous hemangiomas. Most of these are case reports. So coming to the pathology, so there are three types of vessels, three types of patterns which we see. The capillary pattern consists of, as hemangiomas in other part of the body, smaller caliber vessels with abundant loose connective tissue. The cavernous type consists of large vessels with less connective tissue. The other pattern is mixed pattern. Usually cavernous and mixed pattern are common in circumscribed type, whereas mixed type is mostly seen in diffuse. For all practical purposes, circumscribed hemangioma is considered as tumor-like masses, whereas a diffuse hemangioma is considered as a malformation. And in a circumscribed hemangioma, the cells push the melanocytes to the periphery, which can give a pigmented base to the tumor. So secondary changes which are seen in pathology are pigment alterations, rarely ossification, and the retinal changes. So the novel insights in pathophysiology, as I told, the GNAQ mutations are very commonly seen in multiple phacomatosis and neurocutaneous tumors and vascular tumors and pigmented tumors. So this causes dysregulation of the mitogen activator protein kinase, which influences gene transcription and results in abnormal cellular proliferation. Both circumscribed and diffuse are characterized by GNAQ mutations, whereas the R183Q mutations are seen in diffuse type, which is a less severe mutations, and it causes stationary malformation types, which leads to the diffuse form of choroidal hemangioma. Whereas the more severe Q209 mutation is often seen in circumscribed choroidal hemangioma. This leads to tumor-like masses, and if this mutation, if it is present in the endothelial cells of choroid, it leads to circumscribed choroidal hemangioma. Whereas this mutation, if it is present in the melanocytes, it can lead to nevi and melanoma. So coming to the clinical features, it can be an asymptomatic incidental finding, in which case we generally don't treat the patients. And symptoms, most common symptoms in a circumscribed choroidal hemangioma is blurring of vision, 70 to 80%, metamorphosia, floaters, and rarely field defect. Clinically, it is seen as a unilateral, solitary, orange-red solitary lesion, slightly elevated, and it is a posterior tumor, posterior to equator, and most often it is associated with an overlying or an adjacent subretinal fluid. And the height of the hemangioma is usually lesser than the diameter, having a diameter to height ratio of more than 2. So mostly it is slightly flatter lesion, and macula is the most common location, followed by superior quadrant. The secondary changes, the most common being retinal pigment epithelial hyperplasia, RPE changes, fibrous metaplasia, and retinoschisis. So the causes of vision loss in the early stage of the tumors, mostly it is due to subretinal fluid, whereas chronic subretinal fluid can cause retinoschisis, cystoid macular edema, sometimes even a scar, RPE, hyperplasia. All this can lead to chronic vision loss. So our primary aim of management is to pick up the patient and treat when they don't develop these chronic changes. It is not that treatment cannot be done in chronic changes, but the baseline visual acuity will be very good in patients who don't have these chronic changes, and they are more likely to respond well to the tumor, to the treatment. And other rare associations are epiretinal membrane and choroidal neovascular membrane. And choroidal neovascular membrane are mostly seen post-treatment of choroidal hemangioma like TTT, transpupillary thermotherapy, or PDT. So very rarely these circumscribed choroidal hemangioma can have a total exudative RD, which can lead to neovascular glaucoma. In that case, the patient might land up in painful blind eye, and this is the only indication for enucleation in a circumscribed choroidal hemangioma. So investigations in fluorescent angiography, early fine lacy network of vessels is there. So having said a vascular tumor, fluorescent and indocyanal will be the diagnostic modality. And late phase, there is a variable increase in hyperfluorescence with leakage. Indocyanal angiography, which is the choroidal vascular modality, here there is rapid filling with extreme hyperfluorescence and rapid washout with the hyposcyanescent ring. In enhanced depth imaging OCT, which is a newer OCT and now swept source OCT, we see a smooth choroidal elevation with a gentle slope. Along with the choroidal tumor, we also see retinal changes like subretinal fluid, chronic cystoid macular edema, retinal scissus. All this can be picked up in the OCT. These changes can be present over the tumor, and if the tumor is away from macula, over the macula also. And in ultrasound, it is a dome-shaped tumor with characteristically high surface as well as internal reflectivity. This is in contrast to melanoma, where the internal reflectivity is less due to the homogeneously packed cells in melanoma. Whereas in a choroidal hemangioma, the internal reflectivity is very high, the acoustic interface is high, hence we get a high internal reflectivity. And the pattern of ultrasound is similar to an adjacent choroid. And in MRI, it appears slightly iso-intense or hyper-intense to vitreous, whereas post-gadolinium contrast, there is a very good enhancement. So if there is a media opacity with an exudative RD with a choroidal mass, MRI will come for the rescue, for diagnosis. Many a times, amelanotic melanoma and choroidal hemangioma, they are differentiated with the help of MRI. This is a case of a circumscribed choroidal hemangioma. We can see a subtle pinkish orange hue here, which is elevated along with RPE, hyperplasia, and scissus in the macula. The SRF border is very well outlined in the autofluorescence with the inferior RPE tracts, which is an indicative of chronic SRF, which is seen in chronic CSCR patients as well. And we can see the smoothly elevated choroidal contour with scissus. So this is a fluorescent and indocyanal angiography together. We can see the early stippled and late increasing hyperfluorescence. And we can see the clear extent of the tumor in the fluorescent and ICG. This is yet another case of circumscribed choroidal hemangioma presenting with an inferior exudative RD. We can see this choroidal lesion here, and which is seen very beautifully in the fluorescent and indocyanine angiography. In the later phases, there is diffuse leakage because of the RD. And the same lesion is imaged in the choroid in the OCT with the smooth choroidal elevation and schisis. As we can see in this image, the ultrasound, the internal reflectivity is pretty high. So this is our in-house publication on a CNVM in treated hemangioma. This patient, this is the pre-treatment image showing circumscribed hemangioma with the subretinal fluid. This patient underwent PDT with the half fluence mode, and after 8 months, the patient initially responded 3 months post PDT with the vision improvement of 6.5. 8 months after PDT, he developed SRF again. PDT was repeated, and 3 months later, SRF was again present, and the patient was noted to have a CNVM. Most likely here, the CNVM would have occurred to repeated PDT sessions. So, clinical features of a diffuse choroidal hemangioma: an ill-defined mass in the choroid with a reddish-orange hue and indistinct margins. So, splash ketchup appearance is the characteristic description, with ill-defined thickening of the choroid involving more than one zone. Hence, we call it diffuse. And features of Sturge-Weber may be present, as I already mentioned. In addition to macular changes, these patients will have vision loss due to induced hyperopia due to the elevation and glaucoma. And ultrasound, we see a diffuse choroidal thickening with or without subretinal fluid. And optical coherence tomography will show a diffusely elevated choroidal mass with macular changes. In cases of unilateral involvement, it is always helpful to look at the contralateral eye, the ultrasound and OCT, and we can compare to know, because it is not a circumscribed one. Sometimes it's very difficult to appreciate. So in presence of a contralateral normal eye, it is easy to diagnose. So this is a patient who presented with nevus flemmus and diffuse choroidal hemangioma in both eyes. As we can see in the right eye, it has SRF, chronic cysts, everything. And in the left eye, it is so subtle. There is a very subtle choroidal lesion, almost very flattish, but it is seen well in the ultrasound. And I have yet another imaging for this patient. I will show it later. So this is a recent new kid in the block is OCTA. We have a SSOCTA 6x6 mm usually done. Superficial and deeper choroidal slabs are seen. It is a non-invasive tool, and hence it's an excellent tool for follow-up. And in this, what we see is irregular large caliber vessels over the lesion with the circular vascular arcade that acts as a source of vessel. In the active tumors, we see what is known as the club-like lesions in the deeper choroidal slabs, and in the dormant cases, we see signal voids. Also, post-treatment, we can see signal voids and regression of the large caliber vessels. So when they did OCTA post-laser treatment, which is the original old treatment when they started treating choroidal hemangiomas, although SRF absorbs, actually the tumor size or in OCTA, the large caliber vessels are not getting affected. Rather, only the overlying choriocapillary atrophy is seen. Hence, the role of laser in treating choroidal hemangioma is questionable. When we see post-PDT, the changes are seen as early as 3 days. The large caliber vessels become smaller, and in the later effect, they recanalize again, but to a smaller vessel compared to the pre-treatment OCTA. In radiotherapy also, a couple of studies have shown there is actual reduction in the tumor size in OCTA. Thus, OCTA can be an excellent tool for follow-up of treated, as well as like when we observe also, we can see how it evolves. So this is the same patient which I mentioned. So if we see the left eye, it is very difficult to appreciate clinically, but some subtle elevation in the area where I have marked. So in the OCTA, if we see, it's a montage OCTA, choroid and choriocapillary slab. If we see those irregular large caliber vessels in the same area as I marked here. So differential diagnosis of circumscribed choroidal hemangioma, it could be neoplastic lesions or non-neoplastic lesions. Neoplastic lesions, the most important thing we have to rule out, as I said, the beginning of the class is melanoma, especially amelanotic melanoma. Although we don't see it often in our race. And choroidal mets, especially orange-colored choroidal mets, which can be seen in carcinoid, renal cell carcinoma, and thyroid cancer, and choroidal nevus and choroidal osteoma. Non-neoplastic lesions, most commonly central serous retinopathy. More often than not, choroidal hemangioma is misdiagnosed as CSR, rather CSR being misdiagnosed as hemangioma. Sometimes very early subtle tumors with SRF can be misdiagnosed as CSCR, especially with the inferior tracts. And sometimes posterior nodular scleritis, I have a case, so that can also be misdiagnosed as a choroidal hemangioma. Very rarely subretinal abscess in countries like India where infection is higher, it can present with an unspecified choroidal elevation with SRF. That can be mistaken as a choroidal hemangioma. This is a differential diagnosis. I would like to emphasize these 2 points. One is melanoma is characterized by low to moderate internal reflectivity in the ultrasound. Most of the other lesions will have high internal reflectivity. And there is the same thing, the acoustic hollowing is seen, that is high surface reflectivity followed by a drop in the reflectivity. That angle kappa, I hope everybody remembers that. So that is characteristically seen in melanoma. So this is a first case. She was a 42-year-old female who walked in the OPD with a history of renal cell carcinoma. She underwent radical nephrectomy in March 2021 with a blurred vision in the right eye. One can appreciate these pinkish orange lesions here in the right eye. In the right eye it is multifocal, in the left eye it is just in the location where you expect a choroidal hemangioma, and a similar hue is also seen. She is already on immunotherapy. She was advised to continue the same, and if it is not responding, option of radiotherapy is given. So what we have to remember is orange-colored choroidal metastatic lesions mimic more like hemangioma. So they lack the typical FFA ICG features. And in ultrasound, we see typically metastases have exudative RD out of proportion to the lesion. So melanoma, these types of melanoma generally are not confused with hemangioma, except that if there is no view with the total exudative RD, there our ultrasound helps in the diagnosis, as I already mentioned. So these kind of less pigmented melanomas can be confused with the choroidal hemangioma, and there is typically the double circulation is there. And the second is the choroidal osteoma. Sometimes if it is not fully ossified or de-ossified osteoma is also very rarely reported. Those have a pinkish hue similar to hemangioma, and it can be some little bit of calcium will be there in osteoma, which can be easily picked up in ultrasound as well as OCT. One can appreciate the subtle choroidal elevation here. So choroidal hemangioma and CSCR. Apart from both mimicking each other, recent studies have shown that some form of pachychoroid is seen in patients with the choroidal hemangioma in the same as well as contralateral eye. So this is our patient who presented with the 52-year-old gentleman with no systemic illness, with no obvious pachychoroid risk factors. He presented with the subtle choroidal lesion in the right eye. And that time, left eye, some RPA alterations were there. He was noted to have a pachychoroid in the other eye as well. And he underwent TTT to the hemangioma, and he was observed for the left eye because there was no SRF. In the subsequent visits, if you can see, the hemangioma has responded, it has scarred. But at 3 years follow-up, we started noticing subretinal fluid in the left eye. So this part, just superior to macula, we noticed the subretinal fluid here, and a subtle leak was noted. And though it's not a typical leak, and this person was advised a focal laser, but he came back still with SRF, and he was started on eplerenone because there was no typical leak, and he responded very well at 1 month and 2 months follow-up. We have seen he is responding well. In subsequent follow-up, this patient developed the CSR-like picture in the right eye also in the choroidal hemangioma eye. For want of time, I have just shown these 2 visits. And he was treated with a combination of eplerenone and focal laser. So there are numerous upcoming studies, they are showing that this pachychoroid thing, this CSCR type is seen in patients with choroidal hemangioma. We are yet to derive at any meaningful conclusion. So this is an interesting patient. So 52-year male from Nepal. He presented with defective vision in the left eye for the past 20 days. He was diagnosed outside as a case of melanoma, amelanotic melanoma, and referred to us for further management. So we saw the patient, we investigated him. There was a subtle, clinically it is very difficult to appreciate, but we can see the area of SRF demarcated by the autofluorescence, and there is a subtle choroidal lesion with SRF. Here also we see a choroidal thickening. So subsequent FFA ICG just shows one can carefully make out the choroidal folds as if something is pushing from backward. And MRI showed small elevated enhancing lesion with adjacent scleral thickening and enhancing soft tissue and adjacent tenon space. Post IVMP 3 days, so the lesion has resolved. One can appreciate in the autofluorescence. He improved to 7.5 N6. So the diagnosis is posterior scleritis. So it can mimic CSR. It can mimic a choroidal hemangioma. So coming to the management part. So management, as I already mentioned, only symptomatic patients. Asymptomatic patients can be observed. Second thing, the primary goal of management is resolution of retinal changes, that is SRF and cystoid macular edema. The regression of tumor comes as a byproduct. Because even if the tumor regresses, even with treatment, because of surface changes, the vision can be still low. And those patients who have baseline good visual acuity, they do really well. Those who have already developed chronic changes, we have to clearly explain them guarded visual prognosis, and then we have to start the treatment. So the aim of treatment is to preserve or improve existing vision. What are the options we have? We have laser, we have photodynamic therapy, we have transpupillary thermotherapy, we have radiotherapy, and miscellaneous. So laser, time tested, but only thing is it is not as effective, and these days we are not doing it. So the spot size used was 200 to 500 micron, duration 0.5 to 1 to produce a white color change on the surface of the tumor. So after laser, we see a lot of choriocapillary atrophy and vision drop, but the actual tumor doesn't get affected. Hence, there is increased recurrence. So transpupillary thermotherapy, it's a OPD procedure. It works well and it is available. So there is heat-induced sclerosis of vascular channels. Because of the long wavelength and long duration of exposure, there is deep penetration of the laser and it causes heat-induced sclerosis, but the disadvantage is non-selective. So tumors which are posterior with the basal diameter less than 10 millimeter, thickness less than 4 millimeter, shallow SRF, so that the margins of the tumor are well seen, are the ideal candidates. And the laser used is 8-10 nanometers, and the treatment is for 1 minute, long duration. 2 to 3 millimeter spot size which we generally use. The power we start from 200 and it can be increased in 50 or 100 millivolts. So the endpoint will be when we do the laser, we should get a light gray color in the later part of the treatment. So that way we titrate it, and there is 100% SRF absorption and 42% decrease in tumor height described in various studies. It can be comfortably repeated at 2 to 3 months interval. And there are two special situations that we have to be careful is one is juxtapapillary and subfoveal, where because it's basically a destructive non-selective treatment, so we have to spare the disc margin, and in subfoveal tumors we have to consider other forms of management. And recent one is ICG enhanced TTT, where ICG is found to be a weak photosensitizer, as well as it aids in visualization, where ICG is done followed 1 or 2 minutes followed by after ICG we do the TTT. Complications, those cases which have increased thickness, surface changes, and retreatments, they don't respond well to TTT. And damage to RP, branch retinal vein occlusion, recurrent macular edema, scarring, fibrosis, very rarely retinal tear, retinal traction, and hemorrhage. So chorioretinal atrophy and visual field loss can be seen, especially with retreatments. And very rarely focal iris atrophy when broad laser beam hits a partially dilated pupil. And still TTT is a most common modality done in our center, and it works really well in selected cases. So this patient who came with a baseline vision of counting fingers at 2 meters, TTT was done at baseline. So we can see the subtle tumor here, and this is a choroidal elevation with the SRF. At 1 month, 3 months and 6 months follow-up, gradually the SRF reduced. Of course, outer retinal atrophy is there, and vision improved from 3/60, 660 and remained at 660. So next is a photodynamic therapy or PDT, again a OPD procedure. It works very well. The problem is right now it is not available. So here it is selective, and it is a vascular tumor, so it is concentrated in the endothelium, and hence there is minimal collateral damage. Standard dose is 6 milligram per meter square vertiprofen over 15 minutes. 10 minutes the dye infusion is done, and 5 minutes we wait for the activation, and then we start the laser. Usually we use a 689 nanometers laser, 50 joules per meter square power, and 600 fluents and 83 seconds. Single spot for small tumors or largest tumors, we use multiple non-overlapping spots. We calculate the spot size with the help of ICG. We call that laser spot size, which is nothing but the greater linear dimension plus 1000 microns. GLD plus 1000 microns is the spot size which we usually use in PDT. And variations will be double duration, especially if the thickness is more. And with double laser power, full fluence, there are multiple variations, especially when thickness is more and in retreatments. It can be repeated up to 4 times for persistent SRF at 3 monthly intervals. The only thing with PDT is always we need some form of angiography to locate the tumor. So it is invasive and requires multiple sessions, again expensive, and photosensitivity reactions can occur, so that restrictions will be needed. And sunburns, anaphylaxis, those side effects can be there. It can also cause atrophy and very rarely sensory retina damage, visual field effects can be there, and CNVM and PCV can happen. Difficult to perform in tumors which are lying beneath the serous, large serous detachment, same with TTT, as well as little anterior tumors. And this is a patient who presented with relatively good vision, 612 with the subtle choroidal. This is one case which mixed like CSR. We hardly are able to appreciate any choroidal mass. And in the autofluorescence, we see an area of SRF and some RP changes. Then we do the angiography, OCT picks up. This was one case in our institute where first time SSOCT was done to pick up a choroidal tumor. And we found that there is a choroidal hemangioma, and it was treated with PDT, and he did very well. From 612, he was holding on with 7.5. So this is the importance of picking up early, having good visual acuity, so patient will enjoy good vision. So radiotherapy, mainly for cases of diffuse choroidal hemangioma, and with circumscribed or diffuse choroidal hemangioma with extensive RD, total RD. So various techniques, external beam radiotherapy, PLOC, and recent ones are proton beam and stereotactic radiosurgery or therapy, gamma knife and cyber knife. So external beam radiation, time tested again. So mainly for diffuse and, as I said, for circumscribed with RD. But the disadvantage is large area of exposure. It needs duration of treatment is low. However, fractionated low-dose ocular radiation, lens sparing can be done, which will reduce the radiation-related complications. Having said choroidal hemangioma as a posterior tumor, radiation optic neuropathy and radiation retinopathy are inevitable. And it is a cost and availability is always there. And it's responds very slowly. The tumor responds very slowly. And even normal tissues are exposed to radiation. So as we said, cataract, radiation retinopathy and optic neuropathy. This is a child who was 10-year-old. He presented to the OPD with the unilateral RD. And on careful examination, we found some subretinal lesion. In the initial visit, the view was very hazy because of total RD. We did an ultrasound to find, one can appreciate the thickened choroid with the exudative RD here. and we made a diagnosis of diffuse choroidal hemangioma. He had a clue on his face. There was nevus flemmus. So we know this is diffuse and luckily unilateral. And we sent him for EBRT. So this is an ideal case for external beam radiotherapy. And 2 months post EBRT, we were able to image him. We did a fundus photo. One can appreciate the orange hue. And still retinal detachment was there. But on ultrasound, serial ultrasound, we can notice the thickness has come down, the fluid has come down. And 3 months post CBRT also, he was doing well. We have to remember radiotherapy takes a lot of time. But still this kid was responding well. So PLOC, we rarely do because posterior tumor, it might need a notched PLOC, in which case again radiation retinopathy, optic neuropathy are common. It requires 2 surgeries, whereas EBRT is we don't have to do for a surgery, PLOC insertion, removal, those things are not there. However, it is localized. One more thing is there is differential exposure of radiation. It gives more radiation to the base than apex. So it is bit heterogeneous. So that is there. And however, we have it in our center. In selected cases, we can always do it. So proton beam, these are some of the advanced cases because other than TTT, we have to rely on EBRT. If patient is affordable, the following treatments can be suggested. Proton beam irradiation, here it uses charged particles. Normal radiation, they deliver photons or X-rays. These deliver what is called as protons. So they are charged particles. They use a phenomenon called Bragg peak. What is Bragg peak? Bragg's curve is a curve which shows how the protons travel or any ionizing radiation travel through a target tissue. So Bragg peak is the peak that happens just before the charged particles actually hit the tumor. So here it is a tumor. So only at that peak, the amount of radiation emitted is high, which means the surrounding collateral damage is very less. In nutshell, it delivers highest amount of radiation to the tumor. Homogeneous exposure is there, and it is insignificantly scattered. But it is very, very costly, costlier than PDT. So the other disadvantage is, just like PLOC, we need to use tantalum clips. These were the clips which were used once for buccal very long ago. So tantalum clips to localize the tumor, it needs 2 surgeries just like PLOC to put the tantalum clips, localize tumor, and again to remove it under general anesthesia. And then we will have to, just shown in the picture, the person is made to sit in the apparatus like this with absolute immobilization, and the proton beam therapy is done. So it is usually the dose is 20 cobalt gray equivalents given in 4 fractions. It can be fractionated. That is one advantage. And it claims that there is less disadvantage complications of radiation, though it is not nil. There are very mild radiation changes are seen because of the targeted therapy. Proton beam is not a stereotactic therapy, but it has less collateral damage. The actual stereotactic therapies are gamma knife and cyber knife. Stereotactic is delivery of radiation specific to the target. When we deliver a large dose in one day, it is called stereotactic surgery. When we deliver smaller doses in fractionated forms, we call as stereotactic therapy. So gamma knife, it is a form of stereotactic radiosurgery, originally developed for skull-based tumors. So here the problem is the head should be completely immobilized. Again, it needs a surgery. And what is called the legal stereostatic frame. This is the frame. So the patient has to, something like a MRI machine is there, and that is it is fixed. Again, this frame, everything is fixed. And then it takes multiple MRI images are taken at that time for the precision of the radiation delivery. So yet another very advanced thing is cyber knife. Here it doesn't require immobilization. There is a robotic arm with a renal accelerator, and it has multiple detectors. It will automatically adjust for head movements, eye movements. Multiple images are simultaneously taken, and it will deliver the accuracy is 0.5 millimeter without damage to the surrounding structures. It has been tried in lymphomas and melanomas. We have one in-house publication of a successful treatment of choroidal hemangioma with the cyber knife. And the complications are headache, nausea, cataract, and it is long duration and it requires multiple sessions, of course cost. So this is a difference. Gamma knife, there are multiple beams of radiation. The stereotactic works on this principle. Instead of homogeneous delivery, there are multiple beams so that it delivers radiation only to the target, preserving the surrounding tissues. In cyber knives, we have 1400 as opposed to gamma knife. So cyber knife is still more superior form of stereotactic radiotherapy. Miscellaneous anti-VEGF injection, and in very few cases steroids also they have used as an adjunct, mainly with PDT. It helps in resolution of SRF and also to decrease the inflammatory complications of PDT. As a monotherapy, it is not that successful. And I already said enucleation is indicated only for cases of neovascular glaucoma secondary to total RD, long-standing RD due to circumscribed choroidal hemangioma. And oral propranolol, since it works for cutaneous hemangiomas, they have tried, but questionable role, very small case reports. So take-home message is a benign tumor presenting with visual symptoms due to posterior location. DCH, we have to look outside the eye also, outside retina also, glaucoma and skin and CNS. Correct diagnosis based on initial clinical manifestation and ancillary test as well as early initiation of treatment is important. Most common treatment option which we use in our center is transpupillary tomotherapy if feasible. If not, total RD we send for EBRT. The aim of treatment is mainly to improve or preserve existing vision. The primary goal is to clear resolution of SRF, and tumor size reduction comes as a secondary treatment. There are lack of large-scale comparative studies. We really don't know which one works better. Now, we don't have PDT. We see that laser doesn't work. So, we use TTT and EBRT. So, the future scope can be, we can try using a subthreshold laser which is used for retinal angiomas and CSR leaks, whether it can work for choroidal hemangioma. It's a future scope. What I feel. Still, we don't have any studies regarding the same. So these are my references, my acknowledgements. Thank you for patient listening.
Thank you, Janani, for the wonderful elaborative presentation. It was really very good. So most important points what we should remember in hemangioma treatments are, so number one is, like as she pointed out, whether we are dealing with a circumscribed or we are dealing with a diffuse. So one should remember that a circumscribed hemangioma, at what particular age does it grow? Anybody has any clue? Is it a disease which grows in childhood, or is it a disease which grows in an adolescent age, or in the reproductive stage? Which stage of it does it? Because depending on that, no, it is easier for us to see or rather observe these people, or monitoring becomes easier. When to monitor them? Anybody has any idea? Let's start with circumscribed. What age group is the age group which is potential for them to have activity in terms of fluid or growth of the hemangioma itself? When does the hemangioma grow? That is the question. Now it is circumscribed. So we are talking about circumscribed. When does it grow?
The reproductive age group. And then presence, according to what Janani said, 47 years is the main age of presentation. It probably starts growing that time, and then presence around 40 to 47 years age.
So you are in a way right. The circumscribed hemangiomas do not present at the early age group. On the contrary, the diffuse hemangioma will present early. So it is with the growth spurt, when the active organogenesis occurs, that's when a diffuse starts occurring. A circumscribed will start occurring more so with the hormonal changes. And like rightly pointed out, it never grows when they are in the geriatric age group. So it is in the active reproductive age group is when what you see the circumscribed hemangioma actually starting to become active. Or it may be dormant, it will not exude. So we are going to treat these lesions only if they start exuding. So one thing is, in a circumscribed, we will treat if they throw up SRF. Otherwise, we don't treat, because the chances of a glaucoma in a circumscribed is very, very remote. because it does not occupy that much space for it to cause a glaucoma. Whereas in a diffuse, the main problem what we are going to face is too much of exudation. They will rather know it only when they have glaucoma or when they have too much SRF. So for an ophthalmologist, the treatment for a diffuse is very less, because we cannot treat it in terms of with TTT or any other PDT. That is not possible because it is too big a tumor for us to address the lesion. So for a diffuse, the treatment modalities are like what she pointed out, the external beam radiation therapy. But one should not forget, when you're throwing up these children for external beam radiation therapy, the complication of radiation retinopathy is there, because what we do is when we have to treat these lesions for EBRT per se, because EBRT is less costlier. EBRT would cost anywhere around 20 to 30,000 rupees. So that, and for that, the child has to go through multiple GAs in the sense it is going to be fractionated therapy for a 24 or a 25 day long period. So that much is what they require. So when we are giving treatment, the radiation goes for close to a month, and all these sittings are done under GA. So every day the child undergoes GA for an EBRT. And after that, we must also remember, you have radiation retinopathy, you can have cataracts, then you can have dry eyes. So these are the other problems which we always face. And most important, not to forget, these children also have a genetic tendency for other carcinomas. So you are subjecting these children, or rather pushing these children for other tumors as well. So that is yet another thing we should strongly think and rather discuss with the family before we decide whether or not we are going to do an EBRT. On the other hand, if we are asking the child to undergo a cyber knife or anything like that, cyber knife for a circumscribed is a very small thing. So that is quite okay. That is a question of debate whether you want to do a cyber knife or whether you want to do a TTT, because the circumscribed responds very well to TTT also, only given the point that if it is a subfoveal, if you are going to try and do a TTT, then the patient, the propensity for a visual improvement may not be there. But usually these patients, when they come to us, they kind of come with long-standing SRF and things like that. So in that situation, then the main idea would be to resolve the SRF. In that case, if you have a superior quadrant tumors, then you can probably address it better with TDT. Peripapillary and the subfoveal, a small lesion, that does very well with PDT. That is how we kind of stratify this for treatment. With the event that the PDT not being available, we can do a TTT, but we do it in multiple fractions. We don't do it at the same sitting, try to regress that. But in the same sitting, if you're going to do too much TTT, then the scarring will occur. Then if it is a subfoveal lesion, you're going to have problems. So we do it slow paced. So, and we go on for the long frequency TTTs, and then we do it every 3 monthly. So every 3 monthly, we keep doing it for a year or so like that. Then slowly, the tumor starts coming down. So we do not kind of scar it out if it is at the fovea. The idea would not be to scar it out. So there are two ways of approaching this tumor, which is if it is there at the fovea, we don't try to scar it out. We try only to reduce the SRF. So we don't want it to exude. The idea is that, not to scar it down. Because if you're going to scar it down, it's going to be at the fovea, so which you don't want. And if it is at the PMB again, we don't want to scar it down either. And then for these things, anti-VEGFs don't work that well. They work along as an adjuvant along with PDT, but not with TTT. It doesn't work that well because they have different mechanisms of action, so they don't work well with TTT. This is for circumscribed. And as far as the cyber knife or the gamma is concerned, it is usually very rare sporadic reports are there, 1 or 2, and the in-house which we have treated with cyber knife is also circumscribed only. It's not a diffuse. And for cyber knife and gamma, most of the time you will have to do a vitreous surgery. It is like to reduce, it's for a diffuse hemangiomas. We will have to take down the hemangioma, reduce the vascularity, but then the exuding component doesn't go away. So it will not be a one-shot treatment when you do that. So what we do is we kind of do the cyber knife or the gamma, and then we'll have to do a vitreous surgery to drain the SRF, because now the tumor activity will come down but not completely down. So we have to take it down with the vitreous surgery and then follow it up again with one more cycle of TTT based on the ICG. That is how it is being done. So we don't do it that often, because when we do that, you will have to wait. One thing is waiting for a longer time. These tumors don't respond immediately after the fractions of radiation, because these are also fractionated dosages. But we do follow yet another thing. What do we do is low dose. So we ask them to give a low dose radiation. That is in discussion with the radiologist. So you will have to win the confidence of the treating radiologist. So they should understand you and they should have confidence in you. Otherwise, they will never give a low threshold radiation for these children. So what do we do is, instead of giving 50, what do we tell them is, we tell them to do 20 CGY. So when we tell them 20 CGY, the optic nerve, the tendency for a radiation retinopathy for the optic nerve or for the lens, they all come in the range of 50-55. The tolerance level is that much. So we tell them to give 20. So when we give 20, it is a subthreshold types it goes. So in that case, the chances of radiation retinopathy is still not there. So it is not there, and the fluid will come down to some extent, though not completely. After that, once we identify the area of the tumor per se, then we take it down with TTT. So this is what we call as a combination approach. When you have a good team effort, you can probably do that. When you have a good discussion with them, we tell them the plan is going to be like this after they finish, and then we take it over as a combination treatment. This is done for a diffuse hemangiomas. But in yet another problem in diffuse hemangiomas is glaucoma. Most of the time these children end up having glaucoma. So when we have glaucoma, also additional problem is they do not recover in terms of vision. They'll have glaucoma, they'll have long amblyopia because it will be an hypermetropic eye. So hypermetropic amblyopia is very dense and unilateral. So their visual recovery will be very poor. So whatever we are going to do is only an anatomical salvage, not a physiological salvage. That will not be achievable. And their trab also doesn't work well with these situations. That is yet another problem which we face with the diffuse choroidal hemangioma. The child whom you saw, one of the child which she had shown, the retinal detachment. So if you see, that is not, it was a total retinal detachment, in the sense that this child had a detachment almost touching the posterior capsule of the lens. So after 2 months after radiation, after almost 24 fractions was given, after that also you see the SRF is not regressed completely. So what was there, wherein we couldn't see the optic nerve, now we are able to see the optic nerve after 3 months. So we will wait for a couple of months. If it does not regress completely, then probably what we have to do is we'll have to do an external drainage in this particular child. That would be my plan. Another couple of months I'll wait for it. If it does not resolve, because you can give 6 months time, if it does not resolve, then we'll have to do an external drainage. And then after the external drainage is done, then I will have to do a TTT. But only thing is the hemangioma, this width of the hemangioma is too large, because it is almost nearly 12 to 13 millimeters. So that much of 13 millimeters if we are going to do, it is going to be a wholesome amount for us to do. So in that particular situations, PDT would have been really, really good when we have to address that. But even in that also, even with the larger overlapping burns also, we are going to have a problem in these kind of diffuse hemangiomas. So that's always a battle when we have a diffuse hemangiomas. And apart from that, proton beam. Coming to proton beam, it is always better when we do a solid tumor. So proton beam for a diffuse is very, very difficult target to do, because it is not one solid tumor. It is for them to identify or delineate, it is very difficult. And the cost of proton beam is around 55 to 85 lakhs. It's not simple, and when we are going to do that much treatment for a child in which the visual potential is not there, nobody will opt for it. And given the scenario, that has got the least complication, but then not without complication either. So that is also yet another thing, because even then it is not going to dry up the fluid as what happens in a circumscribed. So we must understand proton beam is not any magic or anything. That is also going to go slow, like how an EBRT goes. Only thing is it works best on a solid tumor. So like a melanoma, it is always better, but a diffuse one is like, it's a very thick lesion which goes, so they'll have to do the whole eye again. So either ways there will be complication, but yes, compared to the X-ray, like EBRT is an X-ray driven, so compared to that, that's going to be less. And any other question which you people would like to know, then I'll be happy to answer. Thank you. Thank you.